Hi there, I am Dr. Precious Adadidiodu, a senior lecturer in adult nursing and an international lead for the Department of Nursing at the University of Huddersfield in the UK. I am the principal investigator for this collaborative project that seeks to develop a UK-Ghana partnership to co-develop a dementia referral care pathway for Ghana. Over the past 3 to 4 years, we've embarked on a journey of a research portfolio that sought to estimate the prevalence or the burden of dementia, especially within the Ashanti region, and also because we know that family caregivers are the forefront of taking care of people with dementia. We also explored their lived experiences. And we didn't just end there because we are solution focused and action oriented. We also asked for the coping strategies for such experiences. And we know that as academics, we usually publish and they sit in journals, but that do not really make the impact as expected. So last year, with the research investment funding from the School of Human and Health Sciences, University of Huddersfield, graciously administered through the Office of Strategic Lead Research and Innovation, Professor Philip Brown, we were able to convene almost 100 people here in Kumasi, Ghana, that cut across different cadres of healthcare professionals, psychiatrists, psychologists, mental health nurses, faith leaders from all the different major faiths in Ghana. We also brought together media people were present. We also had community leaders, academics, researchers, family caregivers, people who are living with dementia, and many others.
I'm excited to be part of this dementia project that has been ongoing for a while, led by Dr. Precious Dodu and his team. Last year, they were here to disseminate their findings on their research and on dementia and diabetes. This year, they are here again for us to co-design a framework for the care of people with dementia.
Let me begin by commending the University of Huddersfield, KNUST, the University of Ghana, Konfanoti Teaching Hospital, and others for bringing this partnership to life. Dementia is no longer a condition we can afford to treat as a distant, foreign problem. Globally, an estimated 55 to 75 million people are living with the condition today. As Regional Director of Health, I wish to assure this gathering of the full commitment of the Director General of the service. The Regional Health Directorate stands to be part and ready to support the piloting of this framework, integrates its recommendation into our routine primary healthcare structures, and champion the policy conversations needed to secure its place within our national non-communicable disease agenda.
Your presence here reflects a shared commitment to improving the quality of care and the quality of life for older people living with dementia, as well as their well-being and the well-being of their families and caregivers. As healthcare providers, we understand that healthcare is most effective when it is person-centered, when it is compassionate, when it is delivered through collaboration. I am confident that through our collaborative expertise and commitment, today's workshop will make significant contributions towards developing a dementia care pathway that strengthens healthcare delivery and improves the lives of countless Ghanaian families.
Last year, we did disseminate the findings of our study to a group of people, and based on that, we created solutions. And it was out of that we are here today. As it stands as a country, we don't have any dementia registry. We don't know how many people in Ghana have dementia, but I dare say we have a lot of people with dementia. from what I have said from the WHO data, 60% of the people with dementia live in low and middle income countries, including Ghana. 4 years ago, we got some funding from my institution, University of Huddersfield, and I want to graciously thank them for that, for their support. First of all, we set out to know what the prevalence or the burden is in the Ashanti region. This is where we did the project. And we recruited 800 people. We wanted to know, screen them using the Roland Universal Dementia Assessment Scale to screen them. And interestingly, we had about, in total, 23.4%. When you put men and women together, the dementia risk from the people were 23.4%. Almost 1 in every 4 people we recruited were at risk of dementia. We had 21.3% being men and 24.6% being females. But interestingly, we also wanted to know what factors have a role in developing or of being at risk of dementia. We found that amongst women, especially those who were of a lower age category, were less likely. In other words, lower age was more protective. The lower your age, the less likely you are to develop dementia, which is actually what we expected. So that's for females. Males, health index played a key role. Those who were from households with higher economic power were less likely. Both, one of the main factors that played a role is that those who were more formally educated were less likely to develop or be at risk of dementia. And I guess we can all think about some of the reasons. We had to speak to those who are at the forefront of taking care of these people, who are the primary caregivers. We wanted to know what their experiences are. One of the things they said to us was that they were stressed and burnt out, which is expected. Another thing is that they sacrificed their personal things and they also time commitment. Some even lost their jobs or forfeited their jobs to take care of their family members. It's a big thing, you know. Others had said to us that it even affected their marriage, education, many things. It's the fact that we have a fragmented, or if that's being euphemistic, practically non-existent dementia referral care pathway. In other words, if you have somebody come to the lower tier healthcare facilities, either a district hospital or CHIPS compound, even if they pick it up, it will take a long time before they get to who ultimately will have to support them. And by the time this is done, the condition would have worsened.
Sometimes it gets very depressing and quite hopeless, because a lot of times I work at Kumasi. We are like the tertiary institution, so by the time they come, it's far advanced. Like, there's not much that can be done. So I really think this is a really great program, because we want to look at the referral pathways and how we can get them to come earlier. But I also want us to be looking at how we can offer them these therapies, these services, how we can make sure it's accessible and it's affordable to them.
Dementia care is not actually integrated in our NHIS, and then you could see, you could obviously see that in the middle income or low income communities, a lot of people. I work as a psychiatric nurse, and then there are a lot of people who have been coming from the communities and villages suffering from dementia, and then we can't do much. Sometimes their children or relatives are not even with them. They stay alone in their communities. You give them medication or you give them treatments, guidelines, and then they are not able to follow it.
The first point of call in cases people don't understand is to go to the pastor. But how does the pastor become aware that before you attempt to diagnose things spiritually, you must know the physical dimensions as well? So for personally, if someone comes to me, what I first of all ask is, have you seen your doctor? So after the person has seen or has the knowledge to identify spiritual cases from physical cases, then the person can take it from there. But what I find challenging in our pastoral circles is that most people don't have the understanding and the knowledge to be able to handle things they don't understand. So anything we don't understand, it is prayer. Anything we don't understand, is demonic. And so until we are able to get people trained to understand these realities, we may mishandle issues. And in Kumasi, I've lived here for almost 2 years. Everybody who holds a Bible, microphone, and a speaker is called a pastor.
Like the nurses, most nurses are at home doing nothing. If the government can afford it, maybe they should let them go house to house, the villages. For example, when you go to the north, they have most of the northern parts. Sorry for using them as an example. They used to tag these older women, especially, forget the men, they are witches. So I think maybe if the nurses, our community health nurses, those working currently, or a lot of nurses at home now doing nothing, maybe they can go to house or go to the information centers, the churches, the mosques, and then give them education on one, dementia. And also, if they feel their elderly women or mothers or grandparents are having this kind of behaviors, like talking, like the signs and symptoms, they should bring them to the facility. Maybe we will be able to help them. And also the insurance aspects. Now we've gone to the various places, the houses, the churches and the rest. Now they are bringing them. When they bring them, or maybe we want to treat them, now the cost, how are they going to afford it? So that one to maybe, like others, they've said already, we should find a way to help them, the government, so that the price will come down, they will be able to treat them. And if we do this one, maybe we identify them earlier, even before it gets to the worst stage.
The first thing is that there is lack of knowledge, even among healthcare workers. That's the fundamental thing. It's still not in our curriculum. My recent study about medical schools and their curriculum is not there. So if the doctors themselves don't know what dementia is, what are we talking about? Who will be able to diagnose? Even when you take to the doctors, they say you should take the person home. So I think the first thing is that we should make sure every doctor, every nurse completing this, any school in Ghana, know about the care, because we have more older 60 plus than we had about neonates. And yet we do neonatology, we do pediatrics and talk about them. So it's a basic blind sight. There was a time our life expectancy were in the 40s. Now it's 68. So there has to be a renewal of mind in how we educate our health workers in the country.
When we check the Islamic view on dementia in the Quran, the chapter of the Romans, there's a chapter named the chapter of the Romans in the Quran, verse number 55. Allah explicitly makes mention of dementia and the stages that the human being goes through in life, where Allah says, Allahu alladhi khalaqakum min dha'fin. It is He, Allah, who created you from the stage of weakness. That is when we are infants and babies. Then from that stage of weakness, there will be a stage of strength. Then Allah explicitly goes forward and mentions that after that stage of strength, that is the stage of youth, then there will be a stage of weakness and old age. That in as much as Islam also acknowledges what we term as ruqya, spiritual healing, incantations, it also acknowledges getting medical remedy from professionals, seeking medical advice, and it also acknowledges dementia as an element in our society.
In order for us to leapfrog the UK's model, I was thinking about how best we can use middle-level clinicians to close the gap. Currently, you see that most dementias are being diagnosed by either a geriatrician or you have a consultant dementia specialist just like yourself, or a urologist who is coming in to probably make the diagnosis using DSM or maybe ICD-10 or something like that. But we have a lot of PAs who are in the system. There's no other program for them in terms of their specialty. Most PAs are doing public health and they don't find themselves in this other specialty. So I am thinking that for a tax shifting opportunity. It is best when you enroll persons who have trained in PA to focus on dementia or probably geriatrics or something, for them to help bridge the gap in seeing a consultant. Currently, if you want to see a consultant, you have to book. Secondly, you have to pay huge sums of money before you see a specialist, and that is actually a cost that families will not be able to afford, despite you may have the NHIS. Still, you will have a consultant who will insist that because of his or her specialty, you need to pay for it. And that is it. For the primary care level, that definitely when you see a GP, probably that's free for you, that it can cover. And apart from we having the physician assistants, I think Ghana College for nurses have also started their programs in psychiatry, and then they also have other programs. So if they can also enroll programs pertaining to geriatric specialty, these are the people who may be middle level clinicians who can help to close the gap, before you can reach out to a consultant. Because currently, how many consultants can we actually train, and how many of them can really see all persons with dementia? Estimating the number of people who currently have dementia, those that we are diagnosed, those that we are yet to even know.
The increasing prevalence of dementia actually places significant burden on nurses, because as this person brought the in-law in addition to other patients, and he is not really sick, but it's just because of the symptoms of the old age. That is why she is pushing for the admission. And this is going to add on to the workload of her colleagues. And so beyond the physical burden of the workload, we are also faced with the challenges in communication, because with these symptoms of dementia, it takes a lot of skills to communicate effectively with the patients, and then also managing their safety and all of that within our resource constrained environment. And then we don't have a lot of training in geriatric and dementia care, as we've all emphasized here. And so I think that nurses need support in our training. We need a lot of encouragement. We need a lot of specialist training, so that we can also do our best. Because even if colleagues, are even adding up to this, then we can imagine people who are at home who are not even in the healthcare profession and don't understand anything about dementia.
So we need to educate the relatives, the caregivers, for them to understand what the patient is going through. And when we educate them to understand what the patient is going through, it tends to relieve the stress, because maybe the nurse assessing the patient, and I mentioned something for them to just mention it to me. If they are not able to do it, I am okay, because I know and understand the situation of that patient. So I believe that when the caregiver is also educated, for them to understand their parent or their relatives, they wouldn't be so much stressed about certain things.
The area of just the diagnosis is a problem. And I agree with Doctor when she says that our community health nurses would have a role to play. Not only them, even our MOs. So if we don't build the capacity of these staff in order to catch these symptoms and signs early, we end up with them presenting at very late stages. And as my sister rightly said, how do you differentiate between normal old age symptoms and then dementia? It's very important. So I guess we need to build the capacity of staff, and that is where I will really lay my point.
And I believe that one of the things that perhaps would help is the kind of aggressive carpet bombing advocacy that we experienced some time back, where if it was HIV, you switch on the TV, the radio, anything, there's something on it to bring it to your mind, so that people already have some idea about it, even in the homes. You see, especially in an era where you switch on your radio and there's a supplement for everything. You live near an information center, there's a supplement for everything. And so people try to find their own way around issues before they can finally get to a place where somebody can put a finger on what is happening. Doc made the point about how the curriculum of training doesn't prepare too many people to be able to identify what they are even encountering. I think it is time for that retraining and retooling to begin, not just for the technical people, but so that when somebody's mom or dad at home begins to show certain signs and symptoms, there is enough of an index of suspicion for the person to know that, okay, if I don't know what is happening, I need to find out somebody who knows what is happening. And then I think the final point that I want to make is that this is a good beginning. Frank conversations on what has been missing all along. But I think that if it dies here, many organizations that have even private health insurance, you go to exclusion criteria, mental health. Even the national health insurance itself, for most primary care and all that, they will tell you that mental health issues are exclusion criteria.
What are we doing about our herbalists and traditionalists? Whether we like it or not, friends and relatives will take their people who suffer from dementia to these people. So what are we doing with them? Are we going to involve them in this policy making?
Most of the time when we mention dementia, it's kind of out of reach for us. It is not a common problem that we know of. But now it's catching up with us. For example, the statistics that were shared tells us that dementia has come to stay. But the sad aspect of this is that, are we aware? Do we know? Do we have the tools to manage it? That's the problem that we are saddled with now. Now, if you look at the way we have been looking at dementia, spiritual, religious, also juxtaposing on this, it's a huge challenge. And what do we do even when people have the disease? Or what do we even do to even pick that people are having the disease? So this program is so important to bring all stakeholders together, the policymakers, the traditional leaders, the religious body, and the service delivery, and the researchers, so that all of us together can craft a common pathway, one in identifying the cases, letting people know they really exist, and that it's not that people are suffering spiritual attacks, and also how and what they should do when they have such problems.
I believe that as it has begun, if we increase the awareness creation, especially to community members, I think it will go a long way to reduce the stigma that is related to dementia. And again, I believe that as a health service, because of the low awareness, even in the health insurance, there is no package for its management. And I believe that as we create awareness and increase this awareness, we should also advocate for its inclusion on the health insurance benefit package, so that people living with dementia can also have a way of getting their health bills reduced or catered for. And this will go a long way to reduce the burden on caregivers.
Last year we had people who are living with dementia. They shared their stories, they shared their experiences, and then the caregivers was also part. This year we have more policymakers, we have more stakeholders, we have specialists, we have nurses, we have psychiatric nurses, which is so good because they all come together to help in the care of dementia. The survey that we have taken, that is the pathway for dementia, or talks about the dementia pathway, which is the same as the patient navigation care, should be more emphasized, and they should focus on that, because when someone is diagnosed at the CHIPS compound, the person needs navigation way to the tertiary education or tertiary treatment, so that he or she can be seen. So what I will entreat them to do next time to incorporate patient navigation into the care system of dementia, so that at the end of the day we will have a comprehensive or a holistic assessment for every patient living with dementia.
Based on funding from the Research Investment Funding, School of Human and Health Sciences, University of Huddersfield, we've also brought together stakeholders today to be able to co-create or co-develop a dementia referral care pathway for Ghana. We've had enormous support from the Ministry of Health Ghana. We've had support from their various agencies, NGOs, and also our partner institutions. It is really important at this point to acknowledge the University of Huddersfield in this whole funding and also providing us with support through academics who are supporting on this project. We also thank Kumasi Teaching Hospital, specifically Dr. John Paul Omoyeni, who is the head of the psychiatric unit. We thank Dr. Nana Kwame Egisi-Boateng, who is the director of the Kwame Nkrumah University of Science and Technology Hospital, who is a key member of this project. We thank Joshua Ochre, who is a PhD student at the University of Huddersfield but based in Ghana, working on longitudinal study, which is the Ghana arm. I also thank Professor Warren Peter Gillibrand, who is the acting dean of the School of Human and Health Sciences, University of Huddersfield. Thanking you for your leadership, and of course through your administration and all that, we've been able to get this funding for this project, and you are a project team member yourself, so thank you so much for your enormous support. We also thank Dr. Biba Simkada, who is an associate professor at the University of Huddersfield, Professor Padam Simkada, Dean of Global Impact and Research, University of Chester, UK. We thank Dr. Datel Norman, who is a geriatric consultant or consultant geriatrician, Harrogate NHS UK. We also thank Douglas Enipoku, based at the KNUST Hospital, for his enormous support. Reverend Professor Joseph Osafwedu, who is the director of the Center for Aging Studies, University of Ghana. Dr. Delali Ajwa Dovier for their great support. And then Samuel Salu. These are the project members. We really thank them for their support. We also thank all our guest speakers, starting from those in Accra, Professor Christopher Charles Mate Colley. We also thank Professor Achi Esuman. We thank the Ashanti Regional Director of Health, Dr. Fred Adomako-Boateng, who is a project team member himself. And then we also thank Professor Veronica Millicent Jomeku, who is the Dean of the School of Nursing and Midwifery, Kwame Nkrumah University of Science and Technology. And then, of course, the incoming Vice Chancellor for Kwame Nkrumah University of Science and Technology, Professor Christian Ejari, who is currently the outgoing Provost of the College of Health Sciences. Mrs. Evelyn Amwakon, Deputy Director of Nursing and Midwifery at the Ministry of Health, speaking on behalf of Dr. Hafiz Adam Taher, Director of Technical Coordination at the Ministry of Health. I also want to thank the media who have taken a keen interest in this whole program, because dementia is a big thing, but of course it is masked, it is underreported. So when they heard about this project, majority of them came to cover it. I want to give it a shout to Joy News. I want to give a shout to TV3. I want to give a special shout to Ahimfie FM, Dr. Nana Kojo Jantwa, for bringing us on the morning show to do an extensive education. That's really appreciated. We thank the Investor Relations Office, KNUST. We also thank all participants for the enormous expertise you brought on board to make sure that this co-creation workshop is a success.
And I believe that the kind of insights that they have shared today in particular is something that is going to help improve dementia care in Ghana. Through this engagement, we have come to understand the problem that exists in terms of dementia care, where almost everybody was beating the same drum, lack of awareness about dementia care, even among health care workers, to the extent that even in our DAMs or our health records, there is no diagnosis on dementia in it. And so that actually is a big deal. It's actually a big deal, especially if even at the health facility level, we are not recognizing this condition.
And we hope that we don't end here. We're going to take this further, looking forward to collaborating with the ministry and every other one involved, all the NGOs and the care homes that send their representatives, the academics, family caregivers, everyone really. We want to collaborate, build a bigger collaboration, and be able to move a step further after this dementia referral care pathway. We are looking forward to collaboratively developing a dementia policy for Ghana, stigma reduction campaigns for Ghana, and then of course peer support or network for family caregivers who are at the forefront of quote and unquote this war. Thank you so much, and privileged to be your principal investigator. Stay blessed.